Miss X. Miss X is a 32-year-old black British woman who was diagnosed with HIV after her regular male partner was tested following an admission with bacterial pneumonia to his local emergency department. Please note he was tested for an indicator condition, which is something we do battle to roll out routinely in London, but in this case he was tested. So she was diagnosed with a good CD4 count 540, viral load 46,000, everything else entirely unremarkable with normal routine bloods, wild type resistance, and her HLA status was negative, Hep B and Hep C negative, and no plans for children at the present time. Oh goodness, sorry. So just to highlight whether or not is this a typical patient, a typical female at diagnosis, is she quite young? This data here shows the breakdown by age of all women diagnosed with HIV in the WHO European area between 2006 and 2015. So it's data collected over a decade. The black bars are the EU and European Economic Area, and the hatched bars are outside. But you can see in total that's about 900,000 women diagnosed if you combine those two areas. And actually if we break the age down, if we just focus on women younger than 40, actually that's 65%. So 65% of all women diagnosed in Europe in the last 10 years were aged less than 40. So Miss X wants to start antiretroviral therapy appropriately, and she asks, what antiretroviral therapy should I take? Should I take the same therapy as my partner? And actually we find this is quite a common question in clinic. People like to be on the same treatment as their partners for convenience and missing pills. So of course we know that globally more than half of all women living with all people living with HIV are female. However, female recruitment to phase 3 trials is generally a lot less, of course, and I've just picked some random recent studies, mainly first line and one switch study, but you can see that fairly typical 10 to 15% of trial participants being female. And I think by and large there are more barriers for women entering studies, including pregnancy plans, contraception use, and of course some of the social barriers to participating in trials also. So how do women fare in trials? There have been a couple of large meta-analyses. This FDA study, this is one of the papers that was circulated in advance of the meeting. This is a meta-analysis of 40 different RCTs, incorporating more than 20,000 people, 20% of whom were female. And really the overall message is there is no major difference between men and women. Women who enter trials do just as well as men who enter trials. This paper showed the same. This is a systematic review that included a broader type of trial, and this was published in 2014. They included both developed and developing world settings, and actually, other than a slightly improved survival for women compared to men, there were no major differences. No differences in HIV progression, and no differences in virological or immunological outcomes on ART. And actually, by and large, outcomes are the same for women. I think there is one notable exception, and that's atazanavir-based ART. Now, I know that protease inhibitors are really not necessarily considered a first-line treatment anymore, as we're all well into the integrase era. But certainly with atazanavir ART, there have been some examples where it's inferior to other treatment options in women. Now, the first signal was in a post hoc analysis of ACTG 5202, that being the 4-arm study that essentially compared Kyvexa with Truvada and atazanavir-ritonavir with efavirenz. And actually in women, atazanavir-ritonavir was inferior. There was a significantly faster time to virological failure in women who received atazanavir. Since then, there's been 2 women-only trials. So 2 women-only trials, WAVES and ARIA, and in each of these, Truvada with atazanavir-ritonavir was compared with Stribild in WAVES and with Triumec in ARIA, and in both cases, the non-atazanavir regimen was superior. This was driven mainly by adverse events, and clearly on atazanavir, the main adverse event driving discontinuation is related to hyperbilirubinemia. We know that black African individuals are more likely to have polymorphisms that confer reduced UGT1A1 activity, and that of course is the enzyme that's responsible for conjugating bilirubin. And actually, if you look at these women-only trials, you see a higher proportion of black participants than you do in a typical male-dominated trial. So that may be what was driving the difference. But I think now we would say that atazanavir really is not an optimal first-line choice for women because it's been inferior to other available options. Now, why might women differ? Now, this is a slide summarising the potential pharmacokinetic differences which may explain how women would absorb or metabolise or distribute drugs differently to their male counterparts. There are many different reasons. It is, of course, important to study them, but overall, it probably won't impact our clinical practice very much because, by and large, we give people more than enough drug regardless. You could argue we overdose many people, and certainly Marta's been involved in many trials looking at using lower doses of standard antiretrovirals. And we monitor efficacy, tolerability and toxicity regardless, and we should do that for all our patients. Now, what other antiretroviral considerations might there be for Miss X as a woman? I think mental health, of course, is something we should assess at baseline and routinely in all of our patients with HIV, but there is evidence that women are more likely to suffer from depression and the negative predictors in terms of baseline social characteristics. So the Cranium study, which was a survey in Western Europe of more than 2,500 people, almost 40% of whom were female, showed that women are more likely to be unemployed, they're more likely to have a lower education status, and using the hospital anxiety and depression scale, they're more likely to be depressed than men. In addition, there are some issues that may affect women more, and some of this comes from my personal experience managing women in clinic, that the issues related to stigma and disclosure, shared housing, immigration and finance, though of course not gender specific, I find tend to affect my female patients more. And based on that, I think sometimes, certainly in England, there's a lot of pressure to switch away or to not start the single tablet regimens as we have access to more and more generic drugs. And obviously many people, or most people, prefer to take a single pill. My experience is that on average, my female patients are more likely to express the characteristics where I think they really need a single pill. However, these issues will be detected in any good consultation, and that would be a consultation with anyone, regardless of their gender, of course. Now, I always like to drop in the British HIV Association guidelines because they're so good. But what they really say is you treat women the same as men. You start women on the same drugs and you monitor them in the same way. So what did we do? So we followed the London Regional Cost-Based Guidelines, whereby we're expected to use Kyvexa first, and then efavirenz or second raltegravir as the third agent. Now, she had no contraindications to abacavir. She declined efavirenz, so she started on Kyvexa and raltegravir 400 twice daily. She tolerated it well, and actually we're one of the clinics, along with Chelsea and Westminster and some others, that routinely switch people to an unlicensed dose of 800 milligrams once daily once they're suppressed. Of course, we'll imminently have the 1200 milligram once daily formulation, which I understand will be no more expensive and therefore can replace this unlicensed dose. Now, just coming back to the BEVA guidelines, the one particular paragraph at the bottom talks about PK or pharmacokinetic interactions with antiretrovirals and contraceptives and HRT. So I'm just going to touch on the PK interactions relevant to Miss X. So for contraception, she's using the depot progesterone injection, but takes no other medication. She's a 32-year-old woman, so that's not surprising. Now, thankfully, of course, we all have the wonderful HIV Liverpool website, and this table here summarises the predicted or known interactions between various hormonal contraceptives and various antiretrovirals. Now, by and large, unboosted drugs that we use, other than efavirenz these days, do not exhibit any major interactions. It's the boosted drugs that do. I think it's important to draw attention to atazanavir, ritonavir, and also elvitegravir and cobicistat, whether that's as Gemvoya or Stribild, in that they both have this impact where they increase progestogen exposure. So you get higher levels of the studied progestogens. They've both only been studied with norgestimate. Whether that applies to all progestogens is not certain, because by and large, where studies have been performed looking at the interactions between HIV drugs and progestogens, it's only ever been with one. And if we look at the impact of atazanavir, if we focus on the boosted atazanavir, because obviously we use unboosted atazanavir relatively infrequently, you can see there's approaching a doubling in the exposure to norgestimate when you give it with atazanavir ritonavir. Now, is that important or not? I don't think we know. We know that women living with HIV, like anyone living with HIV, have a higher risk of cardiovascular disease, and most cardiovascular risk assessments tend to focus on the over 40s. Now, certainly our British guidelines don't recommend performing lipids or glucose assessment at all in anyone under 40. Which I'm not sure is entirely the right thing to recommend. My view, it's one of those situations where I actually recommend EACs over BEVA. So I think EACs are absolutely right that we should be monitoring lipids in younger people, particularly before starting treatment. Otherwise, we won't know in their future hypercholesterolemia whether it's actually endogenous or drug-related. And personally, I think we should check either glucose or HbA1c, depending on your local testing policies, in all women on progestogen-based contraception with atazanavir ritonavir or with elvategravir cobicistat. Overall advice when it comes to contraception, though, certainly at home, long-acting reversible methods are preferred. I think the caution should be at times of method change, because when you see a woman in clinic and you start her on antiretrovirals and you take a drug history, she may be on a particular type of contraception. It may be a few years later she sees someone completely different to switch her method. She may not think it's important because for her there's no interaction between the contraception and her HIV meds, and that's my concern, is at times of contraception method change. I think the thing we must all be aware of is emergency contraception advice. So my question to you all is, do you routinely ask your female patients of childbearing potential if they know how to access emergency contraception? Please put your hands up if you ask women routinely. 1. Well done, you. I'm not putting my hand up because I don't either, and I think we really should. We should. No, I'm honest. I'm not going to stand up here and pretend I'm perfect. I'm far from it. Emergency contraception, I've listed the methods here. First choice, most effective, is the copper IUD, no drug interactions. However, accessing coil inserters at the right time is not always easy. So there's 2 medical methods. There's ulipristal and levonorgestrel. Just to summarise the interactions for both, dolutegravir, raltegravir, which she's on luckily, and rilpivirine, no interaction with either. Ulipristal is metabolised mainly by 3A4 and to a lesser extent by 1A2 and 2D6. Levonorgestrel is metabolised by 3A4, so essentially efavirenz may reduce concentrations, boosters may increase concentrations. Certainly for levonorgestrel as an emergency formulation with efavirenz, you would double the dose. If in doubt, double the dose. No one's ever come to harm from a double dose of emergency Levonorgestrel-based contraception. So back to Miss X, all is going well. She sees you in clinic. She says, Dr. Waters, you've told me I need a smear test once a year, but my GP says I can't have a smear test every year. So this summarises the recommendations. So EACS recommends cervical cytology every 1 to 3 years. Now, I did scour the guidelines and I couldn't see what determines the difference. Is it based on what you can get locally? Is it based on smear history? It doesn't specify when you can go to a longer screening interval. If you look at the CDC guidelines for cervical screening, they recommend starting 1 year after first sex. And actually that may mean starting screening a lot earlier than your national programme recommends. At home, we start cervical screening at 25. And that means an HIV positive woman who may have become sexually active at 15 will not have a smear until 10 years after she first had sex. Now CDC say once you've had 3 normal smears, you can go to 3 yearly intervals. If the smear is normal and you have access to high-risk HPV typing, then you can go to 3 yearly after a single normal smear. Now, our draft BEVA guidelines, which are taking some time to get out, we are going to recommend, assuming that this doesn't change in the guideline consultation period, annual smears, but 3 yearly if the high-risk HPV is negative, the smear is normal, but also the CD4 count's above 500. Some of the evidence that CDC base their recommendations on do show a relationship with CD4, and I think above 500, looking at those studies, is the optimal in terms of risk of abnormality compared to HIV-negative women. So my question is to you, so what do you recommend? Who recommends annual smears? Who recommends less than annual smears? That means the rest of you don't recommend smears. Okay, every 3 years. What about the rest of you? Yeah, so you're already, so what we're hoping to implement, you're already doing in the Netherlands. Anyone else who doesn't recommend smears? So the rest of you are tired. Who has access to high-risk HPV typing routinely? Anton, you do. Put your hand up, you do. And so who doesn't? And who doesn't know? Which is okay as well. Who recommends HPV vaccination to the women they see? Who doesn't? Who doesn't care? And who actually administers, who works in a clinic where you can give HPV vaccine if you recommend it? Does anyone actually work in a clinic that gives it? A couple of you, a few of you. So we know, I've put in the graph from Australia because Australia led the way. Australia implemented HPV vaccines to everybody regardless of gender as soon as it was shown to be effective. And they've seen a plummeting in high-grade cervical abnormalities. So if you look from 2007 out to just 2009, a huge reduction. And really, cervical cancer is a vaccine-preventable disease, but sadly it's not. The vaccine's not. I don't know. Ask the chairs.
She's 32 years of age.
Yeah.
So what's vaccination effective if she already has HPV?
Well, so the question is, what's the point in fact, or what's the benefit of vaccinating if somebody already has HPV? I think certainly initially it was considered there'd probably be none, but I think as data emerges, particularly the data looking at using HPV vaccine in sexually active MSM, that actually there is some benefit. The benefit will not be the same degree as if it was someone who was HPV naive, as it were, which is clearly then the optimal time to vaccinate prior to having sex. But we must remember that certainly in immunocompetent people, most people clear HPV and they are reinfected and reinfected and reinfected. So she could well be reinfected with another high-risk HPV type with another partner in the future. So I personally think that the issue is cost effectiveness, of course. How cost effective is it? Certainly at home, the imaginary recommendations are that all people with HIV should be offered HPV vaccine. It's just taking a long time to implement it. Okay. We must remember it's not just cervical abnormalities, and certainly EACTS do recommend anal pap screening in all people who may be at risk, and it's important to note that a history of anal sex is not necessarily predictive of anal HPV. So if you look at HPV in women, about half of them do not report a history of anal sex. So my final thoughts, one thing I think we must always remember is intimate partner violence. It's an important issue in general, but certainly this study from London showed that women living with HIV were much more likely to have experienced recent or ever intimate partner violence than those without. I think it's a thing that, again, we're not necessarily very good at screening for in clinic. I think the issues around disclosure, I think there's been a lot of fantastic work recently showing the benefits of disclosure and how to support people to disclose. This study is interesting from Denmark, and just to point out that although many people felt they would experience issues with disclosure, actually only 7% encountered negative reactions. Now clearly that would be none ideally, but it was much lower than anticipated. And final question for you. Do you routinely discuss uninfectious equals undetectable equals uninfectious with your patients? Always? Only those who are sexually active? Sometimes? Only if asked. I think this should be always. People don't always talk about whether they're having sex. They may not be sexually active because they fear transmission to others, and we should end every consultation with you equals you. Thank you very much.